Hi, everyone. Liz here. I am going to answer some of the pre-submitted questions that both Chris and I promised to answer as we can. So I'm just going to do what I can to answer them. And of course, if you ever have additional questions, you can go to iocdf.org/peace of mind. You can put questions there. And then, of course, you can attend our live streams and submit questions live. And the ones we don't get to go into a document that we do our best to answer, which is exactly what I'm going to do here. Again, please remember any of our live streams and coverage, these are not intended to replace therapy or provide specific interventions or answers to your own therapeutic questions. You should do that with your own clinician. These are really intended for education and support. And of course, if you are in crisis, please call 988-911 or go to your local emergency room if you're in the US and follow your local emergency resources and guidelines if outside of the US. So let's hop in. I'm so excited. Happy Friday. It's end of September, which is wild to think that holiday season is coming up before we know it, but excited to join you guys and answer some questions. The first question submitted was, when my OCD intrusive thoughts or triggers appear, I've learned ways and methods that I can deal with them. To support myself, I do self-talk and remind myself that I'm a loving person and don't want to cause harm to anyone. I was told it was reassurance, is believing in myself reassurance. This is such a good question and one that I definitely want us to address. So I think that it's really important we think about, how do we engage in self-compassion and believing in ourselves versus when does it become reassurance? And so my quick and short answer to this would be, if we're saying things like, I'm not going to harm someone, so we're trying to confirm or deny our intrusive thoughts, then it can become a ritual. And then it's really serving OCD, right? So if I have an intrusive thought that this water bottle is contaminated, and I am telling myself like, oh, but people drink this all the time and they're safe, so it must be safe, or I won't actually get contaminated by drinking this. That is actually confirming or making my OCD bigger. What I mean by that is that we're doing a behavior that reinforces that we need to respond to our OCD, right? Where instead, if I just say like, oh, I'm having the urge to drink this water, sorry, that made no sense. I'm having the urge to give myself reassurance, and because I'm worried that by drinking this water, I'm going to become contaminated. I'm going to choose not to give myself reassurance, drink the water anyways, and who knows? And I know I can do it because I'm strong and I've got this, right? That is some motivation and self-support that's helpful and might make sense and would be okay. But if the motivation or support that we're giving ourselves is really serves as reassurance to confirm or deny the fear, then it is feeding OCD, if that makes sense. So no issue with kind of building ourselves up, giving ourselves motivation, but we do want to be careful if we're saying statements that are actually trying to fight those intrusive thoughts, right? We're battling with them versus just letting them be there and not trying to solve them. Next question is, I'm not a therapist, but I'm curious on your thoughts about being flexible and compassionate and being harsh or direct with OCD. I'm assuming you want to be a little more inflexible if you feel like it's someone's OCD talking, but then be compassionate with the individual. So this is a great question. We 100% want to use compassion. We want to support each other. We want to build each other up and use motivation when we're talking about ourselves, even when we're setting boundaries with OCD, right? So I could set a boundary with a loved one if they're asking me reassurance, where I say like, I'm not going to answer that, that's your OCD. And like, while that is true, I shouldn't answer it probably, and it's probably their OCD, that is kind of harsh and not going to come across really well, especially when we know they're dealing with this thought and dealing with anxiety. But if I say something like, hey, Laura, like, I love you, but I don't love your OCD, and I'm happy to go on a walk with you or help support you in other ways, but I don't want to answer that reassurance because I don't want to make a question, because I don't want to make OCD bigger. This is a way that we're still setting a boundary, but using empathy and using compassion and those things that are critical for us to do in regards to any struggles that people are dealing with. Next question is, what are your suggestions for treating someone with comorbid OCD, PTSD, and TRD? Should something be treated first, and should they be in multiple therapies at once? So if TRD is trauma-related disorder, I would encourage you to watch our live stream. You can go to iocdf.org/YouTube or YouTube/IOCDF, whichever way. Go to our YouTube channel for IOCDF. And there's an entire webinar on OCD and PTSD, and we go through all of this. Next question is, a few years ago, I suffered a traumatic event that caused me to take risks and make mistakes that could have been serious consequences. They did not. I've been forgiven by all involved, yet I cannot stop thinking about the things I've done. I feel that I've made progress dealing with the trauma, which is positive, and it's the aftermath that's been tough. Will ERP work when one has really done things they're ashamed of? I think this is a great question. And what I would say is that it definitely would make sense to me to use a CBT approach, but whether you'd use ERP specifically, it really depends if it's now presenting as OCD. So if it's now presenting as OCD, so we're engaging in checking behaviors and we're engaging in lots of reassurance seeking or things like that, where it might be OCD, you could work with an OCD clinician and see if that makes sense. But if it's more just of being able to process the situation and process what happened, there may be some different approaches that make sense to do. So I think that that's a tough question for me to answer because it's hard for me to know without the other details. But I would think that a good CBT therapist should be able to talk to you about and work with you on how to change the relationship with your thoughts now. What is the link between OCD and premenopause? So I would encourage you to watch. We've done a couple webinars on perinatal OCD where we definitely talk about OCD and hormonal changes, but we haven't done anything specifically on premenopause or menopause. And I think that would be great. So hopefully we can take note and we'll bring on some experts to do a lunch and learn soon on hormones and OCD. Next question is, what does ERP look like in a child who exhibits emotional dysregulation and in addition to OCD is autistic, has ADHD and Tourettes? We started with an OCD a couple weeks ago, but I feel like my child needs DBT in conjunction or prior to ERP. I think my child also has PTSD and ERP can be too much, particularly as someone who's autistic because she's so literal and she's 11. So I definitely think for emotion dysregulation, DBT is the treatment that we would often recommend. With that being said, most kids with OCD, anxiety, and comorbid conditions may have some emotion dysregulation. So there is a piece of emotion dysregulation that's normal, that makes sense, and that we can work with under the realm of OCD or other treatments, depending on the diagnosis. But there's times where the emotion dysregulation is so disruptive or so loud that it needs to be addressed first. So I would really want you to work with a provider to think about it. If it does need to be addressed first, I would recommend DBT. It's often the most evidence-based intervention really that focuses on kind of skills and tools for emotion and dysregulation. But talk to your provider for sure. My daughter suffers from OCD, BDD, and BPD. She's been trying to get ERP treatment for her intrusive thoughts, but due to her poor distress tolerance from the BPD, her therapist wants her to gain skills with DBT before starting ERP. Can you please provide your thoughts on the comorbidity of BPD and OCD/BDD and how it impacts treatment? Any suggestions on what can be done concurrently? I'm concerned that OCD is largely untreated. I'm concerned that the OCD is largely untreated while DBT skills are being learned, and that takes some time. So this is true. DBT skills do take time, and it's hard, right? Again, mental health is often like a puzzle. There's a lot of pieces, and we're trying to figure out how to put it back together. And we don't always know what order makes sense. And sometimes there's not necessarily a right order. But what we do know is that the treatment of OCD, so when you're doing ERP treatment, it dysregulates you, right? When you think about how we do ERP treatment, we're encouraging you to face your fears. You're going to feel anxiety. You're going to feel distress. And we want you to still engage in these activities despite that. And we want you to be able to tolerate those kind of peaks and lows, but to tolerate the distress and to not respond to it. We're teaching you to not respond to distress. And so if you have a BPD diagnosis and distress tolerance is something you really struggle with, we would often want individuals to get DBT first, because the reality is that we already know ERP treatment is going to probably dysregulate someone. And if they don't have strong distress tolerance skills, it will be a very difficult treatment modality to engage in. Additionally, if you know that emotion regulation is already a presenting issue and it's difficult for them to engage in emotion regulation skills appropriately when needed, it's going to be even harder if they're doing ERP and they're even more dysregulated. So we would say to do the DBT first. With that being said, there are many clinicians that specialize in DBT and OCD. And so you absolutely could try to find a provider who specializes in both. If you're thinking about a treatment center, NBI in Florida, for example, they really do a wonderful job of integrating both ERP and DBT kind of combined. So there are options out there. I get the anxiety of like doing DBT and pausing OCD. So you may not have to totally pause OCD treatment. But again, to get into the like really heavy throes of ERP, we want someone to have strong emotion regulation skills. Are there any resources for parents with adult children who are unwilling to seek help and treatment for their OCD? Absolutely. Please visit iocdf.org and also consider the SPACE training. So this is all caps, SPACE, but there are clinicians who are specialized and trained and certified in SPACE. And this is a treatment protocol that's really specific for parents to work with their children. It was kind of developed for more of for children and adolescents, but it also can be used for adult children as well, or considered at least. And then of course there are parent-only support groups. I know if you go to OCD SoCal, which is the Southern California affiliate of IOCDF, you could just Google OCD SoCal and it'll pop up. They have a parent support group once a month. That's a wonderful resource as well. Next question is, I get intrusive thoughts that I want to be sick and I'm scared they have some basis in reality and feel like I'm an awful person. For example, I have moderate to severe OCD and feel like I almost want worse symptoms or another diagnosis. Have you seen this before in those living with OCD, and do you have any advice? So of course I can't diagnose, but like OCD can attack anything. And OCD, if we're wondering if it's OCD, we often say it's probably OCD, right? But OCD can jump to all different subtypes, all different thoughts. The good news is the treatment stays the same. So if you're with an OCD provider, you can think about how to do ERP for these thoughts and how to lean into it versus trying to solve it. Remember, compulsions make us more confused. Solving gets us stuck. So we want to make sure we're not engaging in a lot of compulsions and not trying to solve our questions that OCD throws at us, because we'll get more stuck in the process. Is it normal to require PM anxiety medications long-term when taking a daily medication if the symptoms are not fully alleviated? So I really am not going to answer medication questions because I'm not a psychiatrist, but what I will say, we will try to bring on a psychiatrist because it will be important for us to do a lunch and learn on medication soon, and we can answer all these different questions. So that's sidebar one. But sidebar two is, please work with your specific psychiatrist and do what's best for you. There's never black and white, right or wrong, right? It's what works for you, what makes sense for your presentation and for your symptoms. Why does OCD make me count how many people are in the room at all times? So this is a good question, and I don't know, right? I think the question I would ask is, what would happen if you didn't count how many people are in the room, right? What are the fears? What are the anxieties? What are the reasons for engaging in this behavior, so that then we can target not just the behavior itself of have you start not counting people in the room, but also why do you have the urge to do that, and address the core fear. Next question is, how do I deal with real event OCD that ties in with a taboo mistake? So this is a great question, and it's important because we come across this a lot, where those of us that have triggers about real event OCD, then we feel like we get even more confused or more tied, because it's like, oh, but this is actually real. This is rooted in reality, so it feels different. It isn't different, right? So there might be reality, and you have to address reality the way you would address reality without OCD. But then when OCD latches on, we need to treat OCD as OCD, right? And so we want to be able to say, okay, yes, this might have been rooted in reality, and you dealt with this situation, or here's how it might make sense to deal with the situation, this like without OCD, right? But once OCD is latching on, now we need to deal with the OCD, and we need to address that. And so you want to work with a clinician to really talk about how to address OCD, which is like, where is it lingering? What's the doubt? What are the questions? What are the fears? What are the rituals, right? And how do I address the OCD that is attached to the real life situation? We can't make a real life situation go away, right? But what we can do is like, you address that situation in whatever way, or if it needs to be addressed, but then now we also deal with the OCD triggers around it as OCD. How common are obsessions rooted in the past? They feel so different from present-oriented fears. So this is a good question. And they are really, I want us to remember that our OCD is the worst around whatever it's attached to. So whether it's attached to a past event or a current event, it's going to feel the worst, and it's going to feel so different for us because it's what we're struggling with right now, right? In the future, maybe there's a different trigger, who knows, right? And we have to deal with that differently. But they are common, right? It is very common for us to have obsessions that might be triggers around things that happened in the past. Again, we just talked about real event OCD, which is often something that happened. Now I'm having triggers around it, or something that we fear could happen, right? And what might happen next. trying to get to the next questions and make sure I answer all of them. I have a hard time holding in my guilt over my fears, so I confess them. And before you know it, I'm inconsolable. How do you challenge the urge to confess every fear that comes up? So this is a great question. So what I want to make sure we recognize is that confessing, reassurance seeking, telling, right? So we call it tell, ask, confess, but like whether I'm telling you something, asking you something, or confessing something, it serves as reassurance. And so what often happens, and what I'm assuming is happening here, is that when we start to engage in rituals like confessing or reassurance seeking or telling somebody something, we get more stuck. So we start to kind of spiral, we become more stuck, more confused, more scared, more anxious, and then it's really hard to pull ourselves out of it. And in fact, some of us with OCD might even say things like, man, like, I wish I wouldn't have ritualized at all because I feel worse now than I did early on. And I should have just not given in at all to this or just dealt with it immediately. And so really, how do we deal with it? We start to reduce the rituals and actively engage in exposure. So exposures with response prevention. So we want to stop telling people things, stop confessing, stop asking reassurance, and start leaning into the exposures, the fear, right? Making sure we're not trying to then just like suppress or ignore the fear or hope that it's not there. We want to allow, right, or approach our fears or anxieties that are there. And again, this doesn't mean we have to accept the worst case scenario, but what it means is that we have to acknowledge the thoughts that OCD is giving us and not try to suppress it or get rid of it, and choose to not do rituals around it. Could you please suggest how to use ERP towards met-OCD? I recently realized my OCD has transformed to meta. Although I thought I'm okay, it really turns out the OCD is still here and I hate myself for it. How do I stop hating myself for having OCD? So let's start with the first part, right? Which is that meta-OCD, which is often when OCD latches around having OCD, right? This is treated with ERP just like any other form of OCD, right? So we are going to intentionally do exposures, engage in response prevention, and make sure we're targeting our core fear. So we want to understand what that is. As far as offering self-compassion to ourselves, you know, it's really important for us to treat ourselves the way we would encourage other people to treat themselves. If I were to ask you, if someone else said the statement, what would you tell them? You would probably say things like, I would tell them that, you know, they didn't ask for OCD, this isn't a choice, and they can engage in ERP, they can receive freedom, but also that you shouldn't hate yourself for your OCD. It's not something you want, not something you're choosing to have. And also, is there any strength that can come from having OCD, right? While we don't want OCD and we wish we didn't have it, I do believe we learn a lot about ourselves. We're able to become so much stronger and so much better than the average person after we've sought out treatment and fought and engaged in treatment. And so it's really about, can we use self-compassion, and can we understand that there's an entire community here that has OCD or has lived with higher levels of OCD, and it may wax and wane over time, but that it's not something that we chose, right? It isn't a choice. And really offering self-compassion for ourselves and thinking about the strength that you get from learning how to fight OCD, from being faced with OCD in different ways. That's really important. One of my favorite quotes is, without our struggle, we wouldn't know our strength. Doesn't mean we want our struggle, doesn't mean we want our OCD, but I certainly believe if you live with OCD and you're fighting OCD, you will have strength that other people don't have, and you will start to see and learn so many things that other people don't get a chance to learn. I started an OCD chat mini support group, and most people in the chat completely lost their ability to function due to OCD. They either tried treatment before, including ERP and medication, or don't have access to treatment. I'm running out of words of hope and support. The good thing is that people are still willing to engage in ERP and are interested in learning new skills, but at this point, it's more about surviving versus living a fully functional life. Intensive treatment is not an option. I'm wondering what could help us find motivation. First and foremost, I want to also tell you guys that this is submitted in Russian from Russia. So I first want to just say that I wish there were more resources. I wish access to intensive treatment was available to everyone. And myself, the International OCD Foundation, that's a mission we're working hard on every day of our lives, and will continue to until evidence-based care is readily accessible. In the meantime, I always want us to offer words of hope and encouragement, right? That hope and help are always available, even when we don't think they are, we don't know what that would look like. For example, there are OCD workbooks, there are self-help websites, there's free self-help websites, there's free resources, there's the virtual programming that you can access through IOCDF, right? There are so many different ways and so many different options that you can still receive support, that you can still offer hope and some help to individuals. There's online support groups from the US that you could join. And so go to iocdf.org/peace of mind to be a part of that virtual community and encourage those in your group to be that. But also go to iocdf.org to learn about all the different online resources and help that is available. Next question is, ERP doesn't work for my fear of the pandemic. For me, being around people now is a difference between life and death. If I lean into the discomfort and go out to a store or someone's home, I fear it can cost me my life. I haven't gone anywhere since March. So Beth, I really want to encourage you to consider treatment, especially OCD treatment by a trained clinician, because I do believe that you can get freedom and that you can get help for this fear. I do think ERP will work for this fear, but if it won't, because you're not ready for that yet, it's important for us to think about what do we need to do to help get you ready for treatment, to help get you ready and get you to a place where you can live and function in the world while engaging in your own practices, not OCD practices, but your practices that you feel are reasonable to help keep you safe. But it is a possibility, and I want you to fight for that. Many years ago, I did the first live TV interview about OCD, and there was a huge response, so much so I helped start up the first OCD support group called Obsessive Action. And just after doing this, I was at a dinner party, and my friends all said, "I didn't know you had OCD. Tell us about it," which I did. And when I finished, they said, "What does it do to you?" I said, "Well, take Howard Hughes. He was immensely wealthy, powerful, and adventurous and handsome. He had everything a man could dream of having, but OCD brought him to his knees." Of course, in those days, OCD wasn't really understood, but that's just one example of how OCD can take over your life. Thank goodness there's people like you who understand and are there for us. Thank you. So I just thank you. It is so incredible. You are one of the first advocates, and you were one of the first people spreading the word and spreading the message. And we are humbled and grateful to be able to do this, but we also want to recognize, we're not the only ones, and I hope everybody can join in the advocacy journey, because I really do believe once you engage in treatment and then start doing advocacy, that I really think advocacy is the final leg of treatment. It gives a purpose to our pain. So I'm grateful to be able to do it. Does ERP need to look different when OCD is very pervasive? Someone may successfully do response prevention for one thing, but immediately have another thing come up. Once someone starts, do they need to do response prevention for everything to keep buying into the ERP? So the short answer is yes, right? We need to engage in response prevention across the board. We can't do an exposure once in response prevention, but the next time we do that exposure, we engage in a ritual, or sometimes we do exposures with response prevention, sometimes without. Because again, what is the point of treatment, right? When you think about the goal of OCD treatment and the point, it is that we want to change our relationship with OCD. We want to change our relationship with anxiety. Therefore, in order to do that, we across the board have to change the way we respond to anxiety, the way we respond to our OCD thoughts or our fear. And if sometimes we're responding as if it's scary or dangerous, it just reinforces the cycle. So we consistently have to respond as if we're not scared. We have to act as if we're not scared, and we have to live our life despite the intrusive thoughts, despite the anxiety, without trying to solve them or getting stuck or responding to them. And we do this through ERP, but ERP really should become a lifestyle. And the more you do it with frequency, with repetition, it will become easier. I can promise you that as well. Are you familiar with an OCD treatment approach called rumination-focused ERP? What are your thoughts on this being the sole treatment for multiple months with no apparent progress? Should it be supplemented with other approaches? So I don't know that I'm super familiar with rumination-focused ERP, where the only thing we would do is ERP focused on rumination. Rumination is a ritual, right? When you think about mental rumination, any sort of solving, that telling, asking, confessing, or solving, or ruminating, that's a ritual. It's no different than a hand wash. It's no different than walking in and out of a threshold. It's no different than, doing some sort of repetitive behavior, right? It is a ritual. So absolutely, rumination has to be focused on when we're identifying what your rituals are. We have to remove rumination as a part of treating OCD. But rumination only ERP sounds a little bit different to me. And what I would say though, is that if someone's been doing treatment for months with no progress, we need to say what's going on. Is this treatment working? Am I with the right provider? Do I need to consider somebody who specializes more specifically or has different training? I don't know what the background of this individual is. Or do I need to think about doing something else first, right? Am I ready for ERP yet? Sometimes a lot of the work I'm doing is readiness for ERP before we start jumping in and doing ERP, right? We're getting ready. We're understanding our illness. We're making sure we're on board with the treatment process. We understand why we're going to do it, the intention behind it, so that as we're doing it, we're learning what it looks like in practice, but it's clicking for us so that we can continue doing the work independently in between sessions and once treatment wraps up, right? The goal is not that you only do ERP work and you're only able to use or have the skills when you're with your clinician. You should have them on your own. But rumination only focused sounds a little bit different, but rumination focused, right? We should focus on rumination if that's one of your rituals, but we need to focus on all the rituals and we need to do ERP across the board. If you're not making progress after months of treatment, consider a new provider, consider somebody with different training and background, and go from there. In addition to OCD, some of my other diagnoses are BDD and eating disorder. I have many obsessions, obsessive thoughts and compulsive behaviors from my BDD and eating disorder, along with non-body image OCD. Can ERP help with all of these? It's a great question. So ERP is specific for OCD treatment. Eating disorders are treated using cognitive behavioral therapy, and BDD uses a specific intervention as well. There's a lot of BDD questions. So I'm going to move this question to the BDD ones and ask Chris to answer all of those, because he's really the expert in BDD, has both personal and professional experience. But ERP is specific to OCD treatment. So I want you to think about that. We don't want to use ERP across the board for all of our struggles, all of our diagnoses, but we definitely would use it for OCD first. Next question is, I'm suffering from comorbid disorders that have similar symptoms, OCD and an eating disorder called orthorexia, and I'm constantly trying to decipher which one is which so I can treat it accordingly. To avoid this constant struggle with minutia, could I use ERP for both? It's a great question. There has been, I believe, some research and some understanding of the use of ERP for eating disorders. And I think there has been some success that has shown, but what I would encourage you to do is not to focus as much on what specific treatment, but focus more on your providers and them developing a treatment plan. So there are providers like Kim Quinlan and others who are incredible, who specialize in both OCD and eating disorders. And so I would encourage you to see if you can find a provider who specializes in both. If not, make sure if you're working with an eating disorder specialist and an OCD specialist that they're collaborating, communicating, and working together as well. You want treatment to be collaborative, not siloed. With that being said, an OCD clinician should be able to help you differentiate, here's OCD and here's your eating disorder, and here's how the treatment modalities would look different. And so I'd want you to work with your clinician on this. Last question. I've been recently diagnosed with OCD after 15 years of living with the condition. And as a Brazilian native, I feel I'm having a hard time finding the appropriate line of treatment since our professional environment is highly unspecialized. No experts seem to be reachable, and the only available assistance is lifelong medication, which I despise due to side effects. I would like to know what the role of medication in your personal journey through recovery and what tools we can use to help ourselves with meaningful CBT. And what tools we can use to help ourselves when meaningful CBT is unattainable. So I never talk about medication personally, because I think it is a personal journey and people have to make their own decisions around medication, but should be working individualized with their psychiatrist around what makes the most sense for them. I would never want any of us to share our medication journey and someone else to do the exact same thing, because that's what we did, because it is individualized and it should look different. With that being said, I would encourage you to look into some of the self-help options I was talking about earlier. So for the individual from Russia, very much so as well, there are online options that weren't previously available. So online, so there's self-help books, there's self-help workbooks, there's online resources, there's online support groups. Could you engage in online therapy? I don't know if that's something that would be available so that you could access appropriate evidence-based interventions like ERP for your OCD. I know Katia Moritz at MBI in Florida is from Brazil and does a lot of work in Brazil, so she may be able to help guide you as well. But please reach out to us at info@iocdf.org. And remember, there is always help and there is always hope. as a community, it is our job to come together and help support those who need it more than we do. And I would encourage you to visit iocdf.org, reach out to them for more resources for additional support. And of course, please go to iocdf.org/peace of mind to submit questions and to join us on our future live streams, where we will continue to answer questions, offer education, and support where we can. Thank you all. Have a good day.